It's me a great pleasure to be with you all, and I'm thankful for the EF board for this session. It's always a pleasure to be with you all. Today we are going to focus on what we call the Egyptian CardioRisk'Project. And we are trying to tackle a very important question which has been until recently largely unknown. Are we managing our diabetic patients who present to us with acute coronary syndrome in a proper manner or not? All of us know that diabetic patients presenting with acute coronary syndrome have worse short and long-term outcomes compared to their non-diabetic counterparts. But the question is, do we have data? Let's start by this slide, okay? السلايد مش بيقلب عندي. We are speaking about acute coronary syndrome, so any technical error could be accepted.
Actually, till the technical issue is okay, the data presented by Professor Bendary is data from the CardioRisk'Project. And CardioRisk'Project is the most important project dealing about risk factors in the Egyptians in the past 20 or 25 years. It tried to answer important questions. What are the most important risk factors in Egyptian patients with acute coronary syndrome? What is the phenotype of our patient with ischemic heart disease and acute coronary syndrome? And Professor Bendary is giving us insights from these projects regarding the diabetic patients and the importance of looking at this very high risk category. Patients with diabetes and acute coronary syndrome are considered very high risk category in which aggressive management or all the risk factor is very important, because otherwise you will find these patients coming with another attacks, maybe another myocardial infarction, another stroke. So it is very important to look at the data about this sector of group of patients. CardioRisk'Project, the most important results or data from the CardioRisk'Project about what are the risk factors of the Egyptian patients, we found that risk factors differ between age groups, between males and females. For example, in young Egyptian patients, young adults, 40, 45, 50, the most important risk factor is smoking. In our Egyptian females, the most important risk factors are diabetes, metabolic syndrome, and obesity.
Obesity was the single very prevalent risk factor, about 60%.
Yeah. In the elderly group, the most important risk factor is the hypertension. And that's why if we wanted to adopt a strategy for cardiovascular prevention in Egypt, this strategy should depend on campaign against smoking for our young generations, encourage our women to for exercise, diet control, and check the diabetes, and tell our elderly population that it is not wise for any of us as a physician to tell you that blood pressure 160 is okay because you are 70 years old. No, this is not okay. We should treat hypertension properly. So, Ahmed, what is the most important insight from CardioRisk'Project about diabetic patients?
Okay. We are waiting to fix the technical problem.
That's why I'm discussing with you. Okay. Go ahead.
As a starting point and taking the rope from your kind words, Professor, let's know that Egypt is the most populous country in the East Mediterranean region. This is number one. Number two, we in Egypt provide more than 15% of the total cardiovascular deaths in the region. Can you imagine this? Until recently, as I have said, data despite these huge numbers were lacking regarding the status of diabetic patients presenting to our coronary care units with acute coronary syndrome. We don't know the risk profile, and also we do not know how are those patients managed. So, we carried the CardioRisk project. In simple terms, this was by definition the largest cross-sectional study ever done in Egypt on patients with acute coronary syndrome. About 3,224 patients. All patients are having acute coronary syndrome, whether ST elevation myocardial infarction or non-ST elevation acute coronary syndrome, from 31 coronary care units distributed all over Egypt, Upper Egypt, the Mediterranean region, and even including one center in Sinai, in the period from 2015 to 2018. If you want to know any data about the risk factor profile of Egyptian patients presenting with acute coronary syndrome, and you want to dissect the data according to the diabetic status, the hypertensive status, the dyslipidemic status, this is the way to go. This is a well-calculated sample-sized study. And we had two publications. The first was in the Cardiovascular Journal of Africa. It included the first and second wave in 2019. And the second was in the Journal of Public Health in Africa recently in February, and it included the final data.
Recording in progress.
Professor Ashraf Farida, and he is the president of our Beloved Society, IAVA. I was honored to be one of the co-authors together with Professor Atif al-Bahari, Professor Ahmed Shawqi, but nothing could have been done without all the 36 investigators from all university hospitals, MOH hospitals, and even some primary care units. Thank you all for collaboration. And now to the data. First, what's the prevalence of diabetic patients in Egyptians with acute coronary syndrome? Collectively, type 1 and type 2 diabetes represented more than 43% of all Egyptian patients with acute coronary syndrome, which simply means about 1 in every 2 patients with acute coronary syndrome presenting in the Egyptian coronary care units are having diabetes. And if you want to separate it, look to the incidence of type 2 diabetes, 38.4%, and the incidence of type 1 diabetes, 4.8%. And this reflects the great prevalence of type 2 diabetes in Egyptian patients with acute coronary syndrome, which is of course stemming from the metabolic syndrome. Now to the basic demographics and presentations. And this table speaks it all. And I'd like to highlight 3 or 4 points in this table. First, if you look to the elderly, the age group more than 56 up to 75, you will note that those elderly patients were significantly diabetics as being non-diabetics, and this is important. The second is that if you compare diabetic males to diabetic females, you will notice that the vast majority of Egyptian diabetic patients presenting in our coronary care units are males. Number 3 is that the vast majority of Egyptian patients with acute coronary syndrome are coming from urban areas like Cairo, not from rural areas. And this could be partially explained by the fact that the rural areas are still employing some healthy habits, even in diet, compared to the urbanization of diet, the busy lifestyle, the stress itself could have a factor, and so on. The fifth point about the level of education. And it goes without saying, and it is completely understandable, that if you compare diabetic to non-diabetics, you will find that diabetic patients have had a significantly better chance of higher school and college education compared to those non-diabetics. But finally, there was no significant difference in the mode of presentation. Both groups, diabetics and non-diabetics, tended to present equally with unstable angina, non-STEMI, and STEMI. And if we looked to other atherosclerotic cardiovascular risk factors, and we know that diabetes usually cluster with other risk factors, you will find that all other major risk factors were more prevalent in diabetics compared to non-diabetics, except one, and this is smoking. smoking was significantly lesser prevalent in diabetics compared to non-diabetics. And this could appear strange from the first sight, but it could be explained by the fact that diabetic patients may had a chance for a better smoking cessation educational programs and so on, and this is why the smoking incidence or prevalence was significantly less in diabetics compared to non-diabetics, because let's say that smoking is a voluntary act. However, other risk factors, hypertension, dyslipidemia, obesity, we do not control these risk factors 100% as opposed to smoking. I can tell you, please stop smoking, but I can't tell you, please don't get obese, please don't get hypertension. This is understandable. But what about the past history and the presenting symptoms? I'd like to highlight this fact. If you look to the prevalence of past history of MI, past history of stable ischemic heart disease, past history of unstable angina, or even coronary intervention, all of them were significantly more prevalent in diabetics compared to non-diabetics, which means that diabetic patients usually carry a high atherosclerotic burden when presenting compared to non-diabetics. And this is important. They come with their problems, in other words. And as we know, diabetes is a common pathogenetic factor of what we call silent myocardial infarction or silent ischemia due to the neuropathic process just discussed a few minutes ago. So it was not surprising to find that dyspnea as a typical presentation of acute coronary syndrome was more prevalent in diabetics, 62% compared to non-diabetics, just 50%. What about the anthropometric measures, the lipid profile, for example, and we are very concerned about the lipid profile in patients with diabetes. Look to the body mass index at first. The body mass index, the mean body mass index in diabetic patients was 30, and the mean body mass index in non-diabetics was 22. And this difference, the absolute difference of one kilogram per meter square, was statistically significant. And this reflects the higher prevalence of metabolic syndrome in patients with diabetics compared to non-diabetics. And if you look to the lipid profile, it will be surprising to find that total cholesterol and LDL cholesterol were not significantly different between diabetics and non-diabetics. But when it comes to looking to triglycerides, and we know that hypertriglyceridemia is a very important component of what's called the diabetic dyslipidemia, you will find that triglyceride levels in diabetics was significantly higher compared to non-diabetics. And this is important. Why it's important? These numbers could reflect the great job done by cardiologists, diabetologists, in prescribing statins or lipid-lowering medications in diabetics compared to those non-diabetics. That's why, because diabetics, as Dr. Ashraf said, are considered to be at least at very high or high future risk of fatal, and I'll say it again, fatal cardiovascular events. And now we come to a very important part of the presentation. How are those patients managed? Are diabetic patients managed in the same manner compared to non-diabetics? And this will be good news. And I had these good news. If you look to the incidence of coronary angiography after myocardial infarction or ACS, the incidence of primary PCI, how many patients are subjected to CABG, and even how many patients were treated with thrombolysis, there was no significant difference between our diabetic patients and non-diabetics. This is in and of itself a good news. But one can argue and say this is not a good news all the way. Diabetic patients, as I said, usually have a worse long and short-term prognosis or mortality. So we are expecting to find that diabetic patients are treated a little bit more aggressively than diabetics, but these are the data. Whatever you see the data, these are the data. Finally, when we look to the antiplatelets and parenteral anticoagulations, if you look to the chronic use of aspirin, you will find that the chronic use of aspirin before presentation to the hospital in diabetic patients was significantly higher, 57.9% compared to non-diabetics. This is despite the fact that the Ascend trial recently disputed the fact of aspirin could provide a meaningful net clinical benefit in diabetic patients. But diabetics will remain diabetics, and this is the data. Nearly one of every 2 patients presenting with acute coronary syndrome in Egypt and are having diabetes were using aspirin in the year or the 2 years before presentation. But when they present to the hospital, they were treated equally in terms of aspirin prescription, in terms of clopidogrel and ticagrelor prescription, and even in low molecular weight heparin prescription. And this again feels very good. Our data has gained much attention, and in the cardiovascular news website, there was an article in which we had successfully reached to this person. This person is called Salim Yusuf. He is one of the most renowned and famous cardiovascular epidemiologists in the world, and the #1 cited Google scholar, Google searchers. And he said about our data, quote, "It's useful as a starting point, but hardly surprising. The numbers are very high to me, and you have to act." My final take-home messages, for the sake of time, we can say that in Egypt, most coronary artery disease risk factors are more prevalent in diabetic patients with ACS compared to non-diabetics, except smoking. But the good news is that both groups, whether diabetics or non-diabetics, are treated equally in terms of management strategies. I'm grateful that you listened, and the floor is very open for any question.
Thank you very much, Professor Ahmed Bendary, for your amazing presentation. Give up a solution, because your title is, do we treat acute coronary syndrome patient with diabetes? Probably. What's your message? Do we or we don't?
Actually, the message transcends the presentation itself. The message should be that we have to act before those patients present to us with the final atherosclerotic event, which is myocardial infarction or unstable angina. If you look to the clustering of risk factors, you have a very high prevalence of obesity, you have a very high prevalence of hypertension, and even dyslipidemia. So, a hypertension defeat campaign program, and I have to mention here the 1 million wellness program. This is a very important, peculiar example for such a program. It gained much attention in the news media, and it has discovered many patients with hypertension. Also, obesity, look to the child in the schools, look to their diets, and so on. This is the message #1. Message #2 is that we have to do much effort for providing better management strategies for those patients when presenting to the hospitals. Taking into consideration that diabetic patients are high risk, it was expected to see that those patients were treated a little bit more aggressively compared to non-diabetics. And I'd like to hear the insights of Professor Ashraf Reda and Professor Ahmed Shawi.
Okay, please join us, Bendary. If we ask ourselves these questions by Professor Atif, that what could we do more to our diabetic patients, especially those with acute coronary syndrome, because acute coronary syndrome is a very serious complications of any risk factors, hypertension, diabetes, dyslipidemia. So specifically, we should look at the patients with acute coronary syndrome and diabetes and put him in the proper risk category. This is #1. #2, regarding lipid management. Usually in most of the guidelines, there is algorithm. Start with the statin therapy and wait for 1 month to see if you are at goal. If you're not at goal, put ezetimibe and wait another 1 month and look. And if not at goal, put PCSK9 inhibitor. I think those with diabetes and acute coronary syndrome, management in the intensive care unit may be one of the great changes, that we should start combination therapy from the start regarding lipid management, because this is something easy weapon in our hands. Why waiting for another 1 month or 2 months, especially that the incidence of recurrence of another cardiovascular event is more in the first year. So try in this, at least in the first year, to get your the LDL cholesterol of your diabetic patient as low as you can. And this is, and actually this reminds me of the last comment of Dr. Brownwood.
Yeah.
He proposed a very astonishing strategy, that he proposed that everyone at the age of 30 years is getting 1 injection per year of inclisiran, which is the PCSK9 inhibitor, but another mechanism to prevent cardiovascular disease. I think there is questions from the floor. Go ahead, please. في مايك مستر مايك الفلور لو سمحت.
ثانكس دكتور اشرف، دكتور عاطف، دكتور احمد بنداري، دكتور احمد شوقي. سؤالي عن use of aspirin in primary prevention. الديبيت اللي موجود المعتاد، بما اننا بنتكلم عن ان العيان الديابيتك ما بين ان هو هاي ريسك او فيري هاي ريسك او ماينورتي، يعني ممكن يبقى مودريت ريسك. الاستخدام بتاع الاسبرين في البرايمري بريفنشن، ايه راي حضراتكم فيه؟
Actually, I'd like to call this the aspirin war, حرب الأسبرين. We have recently in 2018 and 19 3 trials that did not provide any benefit, any true benefit of aspirin for primary prevention of cardiovascular disease. The first and the one that relates to our meeting today is the ASCEND trial, which randomized patients with diabetes at high cardiovascular risk between receiving aspirin and the placebo, and the aspirin did result in a significant reduction in vascular events, but at the same time did result in a significant increase in bleeding risk. So we have an equipoise here. The net clinical benefit has not been met. And recently we had the ARRIVE trial in patients without diabetes. It's neutral. And the ASPRI trial in patients who are elderly, more than 70 years old. It was neutral, and there was a significant trend towards increased all-cause mortality due to cancer in those patients randomized to aspirin. So, all in all, the blank recommendation of aspirin as a primary prevention magic pill for all patients is not justified. And in diabetic patients, you have to individualize, because these are the highest risk patients among the board, across the board. And recently, the USPSTF, the United States Preventive Services Task Force, has published an article advocating against the prescription of aspirin as a primary prevention measure for all patients who are elderly than 60. And from 40 to 60, the document said, "Good, you have to individualize." Finally, I'd like to tell you and all my dear colleagues that will always be no alternative to sound clinical judgment. Use your own sense.
Okay, thank you, Professor Ahmed. And I think by the end of these sessions, I would like to thank Professor Inas Shaltut, and it's a pleasure for us in IAVA board to be here in this elegant diabetic patient. Thank you. Thank you.